Hmm. Hello everyone. Good morning to all of you. Very good morning to all of you. How are you guys? How's your preparation going on? How's your preparation going on, guys? Hello everyone. So let's start with the anti-adrenergic drugs. We have completed the cholinergic system. We have completed the anticholinergic drugs. We have completed the adrenergic drugs. And now it's time to learn about the anti-adrenergic drugs plus as well as glaucoma pharmacotherapy. All right. How's you guys? Good morning, Shravani. Good morning, Ambadipuri. Good morning, Safrina, Slima, Naveen, Navini. Okay. Good morning. Good morning to all of you. How's it going, guys? How's the preparation going on? How's the preparation going on, guys? Good. Chalo. Thank you for answering. And let's start with the anti-adrenergic drugs. So these are those drugs which antagonize the receptors, right? Which receptors? Adrenergic receptors, right? So adrenergic receptors are those which are alpha as well as the beta adrenergic receptors. We do have two kinds of adrenergic receptor. That's your adrenergic alpha receptors and adrenergic beta receptors. That's right. Now, so anti-adrenergic drugs, that's your beta blockers to be precise or alpha blockers to be precise, antagonize the receptors action of adrenaline and related drugs, right? These are drugs act by blocking alpha as well as or beta adrenergic receptors. Now, yesterday we have talked about alpha blockers, alpha plus beta blocker, alpha plus beta blocker. Anybody knows about this one? Alpha plus beta blocker, alpha plus beta blocker. Anybody knows? What are the drugs known as the alpha plus beta blockers? Hmm? Yep. Now let's talk about the alpha adrenergic blocking drugs. And now what are the receptors? Alpha, which are the blocking the alpha receptors. And we know that the alpha 1 receptor is there and alpha 2 receptor is there, right? Alpha 1 and alpha 2, right? Now let's talk about that one, right? So non-equilibrium type, that's a non-selective, right? That's a non-selective alpha blocker, okay? Non-equilibrium means non-selective, non-selective alpha blocker, right? That's a haloalkylamine phenoxybenzamine. Phenoxybenzamine is very much useful in pheochromocytoma. Yes, what is pheochromocytoma? That's your adrenal gland cancer. Adrenal gland cancer, right? These are your adrenal gland cancer, pheochromocytoma, right? Now, if I talk about equilibrium means somewhat selective, right? So, if I talk about non-selectives here, non-selectives, these are your ergot alkaloids, imidazoline, hydrogenated ergot alkaloids, or miscellaneous, right? Ergot alkaloids, you know that ergotamine and ergotoxin. Ergotamine is useful in, can anyone tell me? That's your carvedilol, very good. Levetolol, very good. Very good. Very good. Adrenal gland cancer, very good. Now, if I talk about ergotamine, right? So ergotamine is useful in particular which case? We have talked about the ergot alkaloids, which is useful in your which is useful in your serotonergic system, right? Migraine, very good, unbelievable, very good. That's a ergotamine, very much useful in your migraine, right? And which alkaloid is useful in which alkaloid is useful in your uterine contraction, or uterine relaxation? Which one is it? Hmm? Which one is it? Acute migraine. Very good, Shravani. Very good. Monkey the Luffy. Why? Nice. What's your real name? Monkey the Luffy. Chalo. Now let's talk about the hydrogenated alkaloids. Dihydroergotamine, dihydroergotoxin, right? Now imidazoline, phentolamine, and tolazoline. Yes, ergometrine, oxytocic. That's your uterine contractin, right? Ergometrine is very much useful as a uterine contraction, right? Phentolamine and tolazoline, these are your non-selective ones, and phentolamine is very much useful in your cheese reaction. Is very much useful in your cheese reaction, right? Now, miscellaneous chlorpromazine, right? Now, these are the drugs. Alpha 1 selective. Plenty of times they have asked the questions from here. Alpha 1 selective, prazosine, terazosin, doxazosin, alpha-zolocin, tamsulosin, sildosin, right? All the drugs which are having sin at the last, right? Sin at the last. Prazosin, terazosin, doxazosin, alphazosin, tamsulosin, silodosin, right? These are your alpha 1 selective blockers, right? And one adverse drug reaction is very much been associated with alpha 1 selective drugs. Can anybody know about that? Anybody knows about that one? There is an adverse drug reaction associated with alpha 1 selective blockers related to eyes. Anybody knows about that one? Alpha 2 selective, that's your 𝘂𝙎𝘾𝙬. Okay. Alpha 1, alpha 2 selective, that's your 𝘂𝙎𝘾𝙬. This one I'm asking. Alpha 1 selective ka adverse drug reaction, specific adverse drug reaction. Anybody knows about that one? Hmm? Anybody knows about that one? No, alpha 1 selective से dry cough कैसे हो गया? That was a ACE inhibitor that was responsible for dry cough. Glaucoma nahi, they are useful in glaucoma. Floppy iris syndrome. Floppy iris syndrome is an adverse drug reaction when the talk is associated with alpha 1 selective blockers. I am talking about eyes and you are telling me cough, Shravani, huh? Chalo, here you go ahead now. Yes, phentolamine and tolazoline, right? Phentolamine and tolazoline are preferred agents for the treatment of hypertensive crisis. What is hypertensive crisis? That's your cheese reaction. Cheese reaction, cheese reaction takes place the hypertensive crisis, right? And phentolamine and tolazoline is very much responsible for the minimizing this hypertensive crisis, right? Cheese reaction in clonidine withdrawal as well as the cheese reaction. Here you can see. Here you can see. And this question is asked before. That's what I'm telling you. This question is asked before. Tamsulosin and silodosin. Yes, these are very much useful in benign prostate hyperplasia. These are very much useful in benign prostate hyperplasia. Are selective alpha 1 blocker and preferred in BHP. Yeah, that's what I am telling about you. That tamsulosin and silodosin. Yeah, they are useful in benign prostate hyperplasia. That means your prostate kind of condition. But if someone has cataract, also having prostate issues, and then you are taking tamsulosin, then it will be causing the floppy iris syndrome. floppy iris syndrome. Why? Because I told you tamsulosin is your what? Tamsulosin is your alpha 1 antagonist, right? Alpha 1 antagonist. And in the case of this one, you having radial muscles, right? You having radial muscles. You having radial muscles, and these radial muscles have alpha 1 receptors. Alpha 1 receptors. And if you antagonize this one, this will dilate. This will dilate, right? Dilate. Which dilate? These radial muscles will dilate and results into the pupil, right? And that is leading towards the floppy iris syndrome. That is leading towards the floppy iris syndrome. That is the mechanism behind the floppy iris syndrome. I hope it's very much okay to you guys, right? Now, let's talk about the esmolol. Esmolol S, shortest acting beta blocker, right? Nodalol is the longest acting beta blocker. Reversible of vasomotor reversal is due to the propanolol beta blocker. That's a very important statement, right? Vasomotor reversal of the vasomotor reversal, right? Celiprolol is a selective beta 2 blocker having additional weak agonistic activity. Celiprolol is selective beta 2 blocker having additional weak agonistic activity. Whereas contraindications की बात करें, if you talk about the contraindications of non-selective beta blockers, that's your ABCD. That's your ABCD. Asthma, AV block, CHF, diabetes. Can you tell me why beta blockers are contraindicated in asthma, guys? Why beta blockers are contraindicated in asthma? Hmm? Why beta blockers are contraindicated in asthma, guys? Can anybody tell me? Hmm? Bronchoconstriction, B2, monkey the Luffy, very good. Hana? If we take non-selective beta blockers, non-selective beta blockers means they are going to act onto all the beta receptors, right? Beta 1, beta 2, beta 3. And that leads to beta 2 blocking as well. And you know that beta 2 is responsible for the bronchodilation if agonist takes place. But if you block that one, bronchoconstriction takes place. And in asthma, bronchoconstriction is already there, right? Bronchoconstriction is already there, and once you block the beta 2 receptor, there is a severe bronchoconstriction takes place, and that's why the palpitations will occur at that time, and that's why the beta blockers, non-selective beta blockers, are contraindicated in asthma, right? AV block as well. AV block as well. CHF, diabetes, maybe they have been contraindicated, right? Chalo, let's go ahead now. Classification of beta blockers. Classification of beta blockers. Non-selective beta 1 plus beta 2 sympathomimetic blockers, right? Non-selective beta 1 plus beta 2 sympathomimetic blockers. That's your without intrinsic activity, with intrinsic activity, with alpha blocking activity. Okay. So what is intrinsic activity means? What is intrinsic activity? Intrinsic activity is your agonistic property. Intrinsic activity means your agonistic property, right? Somehow it will agonize the receptor, right? Somehow it will agonize the receptor. Without intrinsic activity, these are the propanolol, sotalol, as well as the pindolol. But with intrinsic activity, that's your pindolol. With alpha plus beta property, that's your alpha plus beta, that's your lebetalol and carvedilol. right? Cardioselective, these are very much important. They have asked this question again and again. Yeah, atenolol, acebutolol, bisoprolol, betaxolol, celiprolol, esmolol, nebivolol, and metoprolol. These are cardioselective. Names starting with A to M. AIM starting to A to M. These are your cardioselective. Atenolol, acebutolol, bisoprolol, betaxolol, celiprolol, esmolol, nebivolol, as well as the metoprolol. Right? These are your cardio selective, and cardio selective only should be given when the person is suffering from asthma or if the person is suffering from diabetes, right? Only cardio selective drug which are beta 1 blocker should be given at that time. First generation is your non-selective beta blockers. Non-selective beta blockers, for example, propanolol, sotalol, timolol, nadolol, pindolol, and levobinolol. These are your first generation, which is non-selective beta blockers that is going to act on beta 1, beta 2, as well as beta 3 receptors. Second generation, these are the selective beta blockers. Selective beta blockers, these are selective beta 1 blockers, right? To be precise, beta 1 blockers, that's your atenolol, acebutolol, bisoprolol, esmolol, and metoprolol, right? Third generation alpha blocker with vasodilatory property, selective, non-selective. Selective, labetalol, carvedilol, and cartiolol. Whereas if we talk about the non-selective ones, these are your betaxolol and celiprolol. These are your alpha blocker with vasodilatory property. Now, let's talk about the pharmacological actions of propanolol and other beta blockers, right? Other beta blockers. So here you go. Heart, heart. What will it do onto the heart? Obviously, heart has your beta 1 receptor, and beta 1 receptor, you know that it is responsible for inotropic. Which one is inotropic, right? Chronotropic and dromotropic. What is the difference between these three, guys? What is the difference between these three? Inotropic, chronotropic, and dromotropic. What is the difference between these three? Hmm? Yeah, that is going to decrease the HR, but what is the difference between these three, guys? That's what I'm asking. That's what I'm asking. Inotropic, chronotropic, and dromotropic. Hmm? What is the difference between that? Know or don't know? Just tell me into the comment section. You know it or you don't know it. Hmm? Tell me, you know it or you don't know it. You don't know it? Simply tell me if you don't know it. What is written over here? Knew it, sir. Then why you are not telling me over here, huh? Should I give you a personal invitation to answer me, Shravani, huh? Is it that you want? Heart rate, negative chronotropic. If heart rate is decreasing, that's your negative. If it would be increasing, then positive chronotropic. It's written over here only. And you guys are just being silenced. Force of contraction, inotropic. Conduction, dromotropic. Simply it is written over here. If beta blockers is given onto the beta 1 receptors, what's going to happen? Heart rate will be decreasing, force of contraction is decreasing over there. SA and AV conduction is also decreasing over there. Cardiac output is also decreasing over there. What is cardiac output, guys? What is cardiac output? What is cardiac output? What is cardiac output? Can anyone tell me what is cardiac output? Hmm? Amount of blood pump by heart per minute. That's right. Rate of blood pump to heart. Blood vessel. Okay. What will happen to the blood vessels? Beta blockers, if it is given under the beta blockers, beta 2 receptors, you know that beta 2 receptor is present in your smooth muscles, right? Smooth muscles and your skeletal muscles. The smooth muscles, if you block the smooth muscles receptors, that's a beta blockers, beta 2 receptors, what's going to happen? Initial rise and then fall in PVR. What is PVR? Peripheral vascular resistance. Peripheral vascular resistance. Okay, peripheral vascular resistance, decreasing the cardiac output, decreasing the systolic and diastolic BP, and also decreasing the renin release from Jg cells of the kidney. That's a beta 1, right? Respiratory system, bronchoconstriction will take place, right? Beta blockers, beta 2 receptor contracts the bronchial muscle, bronchospasm in asthmatic and COPD patient. Beta blockers hence avoided in asthmatic and COPD patient because it will do worsen the things due to the bronchoconstriction, right? Skeletal muscles, beta blockers, useful in stress-induced tremors. Useful in the stress-induced tremors, causes muscle weakness and tiredness on the chronic use. Glycogenolysis is being decreased, and lipolysis that provide fuel to the muscle will also be decreased. Exercise capacity will also be decreasing at that time. Now, if I talk about beta blockers, beta receptors are present in your ciliary muscles to be precise, right? Beta beta receptor are present in your ciliary muscles. Which muscles? Ciliary muscles, right? And these ciliary muscles produces what? Aqueous humor. If you inhibit the beta receptor that is present in your ciliary muscles, your aqueous humor secretion will also be decreased. Will also be decreased. And if the aqueous humor secretion is decreased, what is going to happen? Intraocular pressure obviously is going to be decreases as well, right? Now, metabolic effect. Beta blockers inhibits the glycogenolysis. Inhibits the glycogenolysis. What is glycogenolysis? Why should I ask? Glycogenolysis is your breakdown of glycogen. Delay hypoglycemia recovery, increases the HDL. HDL is your good cholesterol. LDL is your bad cholesterol. Increases the risk of coronary artery diseases. Now let's talk about, in summary, pharmacological actions. That's your heart decreases the heart rate, force of contraction is decreases, cardiac output is decreases. Blood pressure decreases into the blood pressure blockade. Respiratory system, bronchoconstriction takes place. Eye reduces the aqueous humor, so intraocular tension is also reduces. Metabolic increases the LDL and decreases the HDL, right? Increases the LDL and decreases the HDL. Uterus, relaxation of uterus. Local anesthetics, propranolol has some local anesthetic property. That's your local anesthetics, right? Chalo. Now properties. If I talk about the properties, highly lipid soluble, that's your penbutalol as well as a propranolol. These are your highly lipid soluble drugs, right? High water solubility, bisoprolol, esmolol, acebutolol, sotalol as well as a timolol. These are having high water solubility. Longest acting, nadolol. Shortest acting, esmolol, right? Maximum bioavailability, penbutalol and penbutalol since it is highly lipid soluble. Maximum bioavailability 100%. Minimum bioavailability 30%, that's a propranolol and carvedilol. Maximum plasma protein binding, that's a carvedilol. Maximum plasma protein, minimum plasma protein binding, that's a celiprolol. Note this things, alright? Chalo. Drug of choice related to autonomic nervous system. Okay. Drug of choice. Open angle glaucoma, latanoprost is being used as a drug of choice. What is the latanoprost? In which condition latanoprost is being given, guys? What is the category of latanoprost? What is the category of latanoprost? Hmm? What is the category of latanoprost? Category I am asking. I am not asking ki where is this being used. I am asking what is the category of the latanoprost? Prostaglandin analog. But which prostaglandin analog, Lakshmi Priya? Which prostaglandin analog? Hmm? PGF2 alpha analog, that's your latanoprost, bimatoprost, right? These are your PGF2 alpha. Angle closure glaucoma, acetazolamide is being used over there. There are two types of glaucoma, open angle and angle closure, right? Angle closure may acetazolamide is being used, which is your carbonic anhydrase inhibitors, right? Carbonic anhydrase inhibitors. Belladonna, atropine, or datura poisoning. That's your physostigmine is being used. Drug-induced Parkinsonism, anticholinergics like benzhexol, biperidine, procyclidine, these are being used. Postural hypertension में flutiricotasone is being used. ADHD, methylphenidate, cheese reaction, phentolamine, tolazoline, right? Alpha, non-selective, alpha 1 plus alpha 2 blocker, right? Raynaud's phenomena, CCBs, calcium channel blocker, that's a nifedipine, amlodipine. Beta blocker poisoning, glucagon is being used over here. Since beta blocker is going to decrease the CAMP levels, whereas glucagon is going to increase the CAMP levels. That's why glucagon is being used in your beta blocker poisoning. Performance anxiety, propranolol is being used over there. Now, shocks, plenty of shocks we have already discussed about, right? Cardiogenic, that's your dopamine and noradrenaline, which is given in your cardiogenic shock, right? With oligouria means removal of the carbohydrate as well, yes? Then dopamine as well. Anaphylactic, I told you that's your adrenaline, right? Distributive noradrenaline and phenylephrine. Septic shock, microbial shock, that's a broad spectrum antimicrobials is being given at that time because you will be having a lot of infections at that time, right? Infections at that time, broad spectrum antimicrobials are being given. Shock due to adrenal insufficiency means the steroids which is used to be produced inside your body, it's not right now being produced as it was, right? So corticosteroids are being given. Hypovolemic, loss of blood. The fluids, that's your crystalloids, dextran, plasma volume expanders, right? These are being given in that condition. Very important table, I'm telling you again, they have asked questions from here. Now let's talk about the drug used in glaucoma. What is glaucoma, guys? Glaucoma is your progressive form of the optic nerve damage. Everybody knows that your eyes has posterior part in your retina. Retina is in your posterior part, and with the retina you have your optic nerve, right, which sends signals towards the brains, right, to see the things, right? So optic nerve damage is a progressive form in glaucoma. In glaucoma, progressive form of optic nerve damage. And how is it take place? That is due to the increased intraocular tension. That is due to the intraocular tension increases. How much it is going to increase? Increases the 21 mm Hg. If it is increasing above the 21 mm Hg, then you have the glaucoma like condition. That's why whenever you go for the ophthalmic checkup of your eyes, they used to check your pressure first. They used to check your pressure first. That's why they used to check your pressure. They will get to know you will have you either you have glaucoma or not, right? Chalo. Now types of glaucoma: open angle glaucoma and close angle glaucoma. Open angle glaucoma is when the space between the ciliary muscles and your um your iris, ciliary muscles and your iris is open. That's your open angle glaucoma. Close when the angle is closed over there. That's your close angle glaucoma. Closed angle glaucoma में only surgery is required. No drug is useful over there. Only surgery is required. Hence, open angle glaucoma में plenty of the drugs are very much useful into that one, right? Now, if I talk about treatment of the acute congestive glaucoma, that's a hamburger. H for hypertonic mannitol, which is a osmotic one, है ना? So it will reduces all the water fluids, whatever is present over there, you aqueous humor, and excrete out by the trabecular meshwork or uvuscular meshwork. A is your acetazolamide, that is going to be in decrease your carbonic anhydrase enzyme, and you know that carbonic anhydrase enzyme are very much responsible for your carbonic anhydrase enzyme is very much responsible for your secretions, right? Secretion of fluids, secretion of fluids, right? Carbonic anhydrase enzymes. So M for meiotic, pilocarpine is being used. Pilocarpine comes under which category, guys? Pilocarpine comes under which category? And to be precise, beta blocker, timolol is being used over there. Timolol is a non-selective beta blocker. Timolol is being used over there. But I am asking, where do we see pilocarpine? What is the exact class of the pilocarpine? Hmm? What was the trick when I told you about this one? Yeah, alkaloid cholinergic agent, cholinergic agonist, direct acting or indirect acting, direct acting or indirect acting. That's why I am saying. Tell me the exact one. Tell me the exact one. That's why I'm saying exact one. Is it synthetic or is it alkaloidal or is it natural? Is it direct acting or indirect acting? Array my pillow. Array give me my pillow. Yes. Yes, that's your direct acting natural alkaloid, right? These are your direct acting natural alkaloid. Pilocarpine. Pilocarpine has a imidazoline ring, right? Chalo. Meiotic. Okay. Now, latanoprost, very good. है ना? Latanoprost causes the growth of eyelashes. Eyelashes. These are your eyelashes, eyelashes. So, these increases the growth of eyelashes as an adverse effect, which is utilized in the treatment of hypotrichosis. What is hypotrichosis? Hypotrichosis means someone who is in the state of getting the chemotherapy, right? And you know that in chemotherapy, your hairs gets loss, right? So in that case, latanoprost, if that person is also suffering from glaucoma, then latanoprost increases the eyelashes growth. So hypotrichosis will be diminished at that case, right? Apraclonidine can be caused the lid retraction. Anti-glaucoma drug causing drowsiness. This is your brimonidine. Okay. Now, this is your normal eye and this is your glaucoma eyes. Okay, so you have that one, a trabecular meshwork. What is trabecular meshwork? Trabecular meshwork is just like an exit for aqueous humor. Exit for aqueous humor. Yeah, for example, this is your bathroom. This is your bathroom, and you have opened the tap. You have opened the tap, and now it is being going that side. But this is your outlet. This is your outlet through which the accumulated water is going outside, right? In your sewage, whatever it is, right? So this is your outlet of the thing. So if your outlet gets blocked, if your outlet gets blocked, what will happen? What will happen? Your water will be getting accumulated over here, right? So if your water is getting accumulated over here, is it going to increase the pressure over here or not? Is it going to increase the pressure on the walls or not? Obviously, it is going to exert the pressure onto the walls. Same that is going to happen over here as well. Same is going to happen over here as well. That's a trabecular mesh up. Trabecular meshwork is getting blocked. Yeah, is getting blocked. Build up of the aqueous humor fluid will take place. Build up. Here you have the build up of the aqueous humor, and that is what increases the intraocular tension, right? And that is what glaucoma itself, if it is increasing above 21 hg, that's your glaucoma like condition, damage to the optic nerve. You got it or not? You got it or not? Hmm? Yes, so thank you so much. Now now apart from trabecular meshwork, we do have another meshwork that's known to be as the uveoscleral meshwork. That is also known as the uveoscleral meshwork. However, 60 to 70% drainage is being um, carried out by the trabecular meshwork, but rest of the drainage is quite related with the uveoscleral meshwork, right? And here is the one where PGF2 alpha analog works. Here, PGF2 alpha analog works over there, right? So, what are the approaches to decrease the glaucoma like condition? Either you have to decrease the aqueous production, right? Either you have to decrease the aqueous production, or you have to increase the trabecular meshwork, trabecular outflow, trabecular outflow, yeah, or either you have to increase the uveoscleral outflow. Uveoscleral outflow. These three mechanisms, or you can say these are the three approaches that can be done in order to reduce down the glaucomic condition, right? Chalo. Now, here you got the answers. Drugs used in glaucoma: Either you have to decrease the aqueous secretion, or either you have to increase the aqueous outflow, either by increasing the trabecular outflow or either increasing by uveo-scleral outflow. Very simple, right? So aqueous secretion, alpha 2 agonist, beta blockers, as well as the carbonic anhydrase inhibitors. Yeah, ABC, A, B, C. Aqueous secretion down will be ABC. So A for alpha 2 agonist. Alpha 2 agonist, you know that alpha 2 is associated with GI mediation, right? That is associated with GI mediation. And if you agonize this one, alpha GI mediation, so what is going to happen? Hyperpolarization will take place. Hyperpolarization takes place and reversing the things will be happen, right? So alpha 2 agonist apraclonidine and brimonidine, which was causing the lid retraction, that is very much useful in order to decrease the synthesis of aqueous humor, right? Beta blockers, I told you that ciliary muscles have the beta receptors, and if you block the beta receptors, for example, betaxolol, levobinolol, timolol is used to be the prototype drug, whereas cartiolol and metoprolol, these are your other beta blockers, right? Earlier, timolol was the drug of choice. Timolol was the drug of choice. Since it is a non-selective beta blocker, we have understood about that one. Yep, we have known about that one, that timolol is your non-selective beta blocker, right? If it is non-selective beta blocker, yep, and if it is taken ophthalmically, and if it is taken through your eyes, obviously through your drop. So if somehow it got systemically absorbed from there, it will precipitate the other complications. Which complications we are talking about? Hmm? Which complication it will produce, guys? Which complication it will produce? Hmm? If it is absorbed systemically through eyes, and you know that these are your non-selective beta blockers, which complications will be arising at that time? That's what I'm asking. Serious complications. Which serious complication you will be seeing at that time if you take non-selective beta blocker vinolizumab? Huh? Bradycardia. What is written over here? What is written over here? Contraindication of non-selective beta blockers. Hmm? What is written over here? If non-selective beta blocker gets absorbed systemically, what is going to happen? ABCD. What is ABCD? Asthma, blockade, AV blockade, CHF, diabetes. Simple. And none of you answered me. None of you. We have read just before, right? But still. Alright. So timolol was used to be the drug of choice for glaucoma, but since it starts absorbing in your systemic circulation, it causes the non-selective beta blockers contraindication kind of a things. So asthma can be produced, asthma can be worsened, AV blockade, diabetes can be worsened, right? So those kinds of things. So now it is not a drug of choice. The drug of choice is your PGF2 alpha. PGF2 alpha analogs are your drug of choice for glaucoma, DOC. That's a latanoprost, bimatoprost, right? Those kinds of things. Now, carbonic anhydrase inhibitors. You know that carbonic anhydrase inhibitors, carbonic anhydrase is very much responsible for the production of aqueous humor. So if you inhibit that enzyme, brinzolamide, acetazolamide, dorzolamide, carbonic anhydrase are bad. Carbonic anhydrase are bad, just like the 𝘂𝙎𝙎 sir. 𝘂𝙎𝙎 sir is also very much bad, right? Brinzolamide, acetazolamide, and dorzolamide, these are your carbonic anhydrase inhibitors. Now, if I talk about aqueous outflow, we have two outflows, trabecular outflow and uveocellular outflow. Uveocellular outflow, PGF2 alpha analogs, that's your latanoprost and bimatoprost. Trabecular outflow, how it will be increasing the trabecular outflow? Myotics. Myotics are the ones which increases the trabecular outflow. Also, alpha 2 agonist, that's your dipivefrin. Dipivefrin is what? It is the prodrug of adrenaline. It is the prodrug of adrenaline. Pilocarpine and physostigmine has also been used as a myotic, right? And also you can see the 𝘂𝙎𝙎𝙎𝙬 over here. 𝘂𝙎𝙎𝙎𝙬, which was the organophosphate kind of a drug, 𝘂𝙎𝙎𝙎𝙬, right? 𝘂𝙎𝙎𝙎𝙬, which is also useful in the glaucoma as a myotic drug, right? Keep laughing, Shravani. That's what you do always. Types of glaucoma. Types of glaucoma, open angle, that's your lens. Here you can see trabecular meshwork, and these are your ciliary muscles, right? Ciliary muscles have some open angle over there. But if you see here, close angle, this is your trabecular outflow, which is much close in that one. That's why surgery is required in your close angle glaucoma. There is a progressive rise in IOP, but there is a rapid rise in intraocular pressure, right? Dipivefrin, which is a prodrug, gets into the cornea, converted into the adrenaline, acting onto the alpha 1 receptor and alpha 2 receptor. Alpha 1 receptor, blood vessel, alpha 2 receptor decreases the aqueous secretion, reduction of IOP, and hence also increases the uveocellular outflow, trabecular outflow through beta 2 receptors. Acetazolamide, DOC for your closed angle glaucoma. Alpha 2 agonist act by increasing the trabecular outflow and decreasing the aqueous humor secretion. Prostaglandins analog are now considered as the first line drug. What I was talking about. This one. Prostaglandin are now considered as the first line drugs. Current approaches of the treatment of open angle glaucoma, that's a topical beta blocker. Topical means you have instilled the timolol, topical beta blockers. Brinzolamide, dorzolamide, these are your acetazolamide, these are your bad, carbonic anhydrase inhibitors. Latanoprost and other PG analogs. Brimonidine, idiopsychitis, brain depression. Pigmentation of iris, growth of eyelashes, fluid in macula, these are your PGF2 alpha adverse effects. Apraclonidine, lid retraction, that is what the adverse drug effect of the apraclonidine. Fingertips question. Here you have the first question. Tell me the answer. Beta blocker that decreases the both systolic and diastolic pressure is propranolol, sotalol, atenolol, and nebivolol. Which one is it? Both systolic and diastolic. Propranolol, sotalol, atenolol, or nebivolol. Systolic is what? Systolic pressure is filled when the blood is going to fill in your heart. contraction kind of a thing. Diastolic is a relaxation kind of a thing. Diastolic is also responsible for your um, when the vasodilation takes place of your blood vessels, that is also responsible for your diastolic blood pressure. That is obviously going to be your atenolol. Sorry, nebivolol. Yes, nebivolol. Yep. Following are non-selective beta-adrenergic receptors except propanolol, alpranolol, atenolol, or oxapranol. Following are the non-selective beta blocker except. So we are talking about the cardioselective ones. We are talking about the cardio-selective ones. Following are your non-selective beta-adrenergic receptor antagonists except propanolol, alpranolol, atenolol, or oxapranol. We are talking about the cardioselective ones. Which one is cardioselective? Over here. Which one is cardioselective over here? Hmm? Which one is cardioselective over here? That's your C, atenolol. Good. Following are the beta 2 agonist except beta 2 agonist except salmetrols, dobutamines, salbutamol, or terbutaline. Which one is beta 2 agonist except that's your dobutamine, right? Following are the alpha 1 selective antagonist except prazosin, doxazosin, terazosin, or phenoxybenzamine. Chalo, give me the answer. Following are alpha 1 selective antagonists except prazosin, doxazosin, terazosin, or phenoxybenzamine. Which one is it? That's a phenoxybenzamine. Where phenoxybenzamine is being used, guys? Where phenoxybenzamine is used, and what is the category of phenoxybenzamine? If it is not the alpha 1 selective blocker, then what is the category of phenoxybenzamine? Hmm? What is the category of phenoxybenzamine and where it is being used? Hmm? Where it is being used? Pheochromocytoma. That's right. Beta. Acha. What is the category of phenoxybenzamine? That's what I'm asking. Hypertensive crisis. Very good. Hypertensive crisis में phentolamine is been used, Lakshmi Priya. Cheese reaction. Phentolamine and tolazolene. Alpha 2 antagonist among the following is euhembine, butoxamine, phenylephrine, or clozapine. Alpha 2 antagonist I'm asking. I'm not asking alpha 2 agonist. Beta halo alkylamines. That's right. Non-equilibrium. Non-equilibrium. Right. Alpha 2 antagonist among the following is euhembine, butoxamine, phenylephrine, clozapine. Which one is it? That's your euhembine A. That's right. But if I ask about that one, alpha 2 agonist, if I talk about alpha 2 agonist, then if I ask about alpha 2 agonist, then hmm, alpha 2 agonist, then phenylephrine. The following are selective beta blockers except pindolol, bisoprolol, esmolol, or acebutolol. Pindolol, bisoprolol, esmolol, or acebutolol. Selective beta blockers except clonidine as well. Clonidine was, yeah, alpha 2, but I am asking about the alpha 1 agonist, then it's your phenylephrine. Clonidine, brimonidine, euhembine, methyl dopa, that's right. Following are selective beta blockers except pindolol, bisoprolol, esmolol, or acebutolol. That's your pindolol, right? Pindolol. The alpha agonist used in glaucoma is ritodrine, brimonidine, guanafacin, or guanabens. This one. The alpha agonist used in glaucoma is ritodrine, brimonidine, guanafacin, or guanabens. That's your brimonidine. Yes, brimonidine is causing the lid retraction, right? What is the category of ritodrine, guys? What is the category of ritodrine? What is the category of ritodrine? And what is the category of guanabens? What is the category of guanabens? Hmm? Tell me fast. Uterine relaxin, very good. Ritodrine, very good. And what is guanabens? What is guanabens? Hmm? Yeah, that's right. But guanabens, I'm asking. Adrenergic neuron blocker, that's your guanabens. Chalo. The beta 1 blocker with a weak additional alpha 2 agonistic action is okay. Beta 1 blocker with a weak additional alpha 2 agonist action. Celiprolol, propanolol, atenolol, or metoprolol. Which one is it? Which one is it? Celiprolol, propanolol, atenolol, or metoprolol. Which one? Celiprolol. Long-acting beta-adrenergic receptor agonist includes long-acting albuterol, salmeterol, perbuterol, or orciprenaline. Which one is it? Hmm? Which one is it? Long-acting beta-adrenergic blocker. Long-acting beta-adrenergic receptor includes long-acting, guys. Very simple. Very simple. Hmm? Wow. Albuterol is nothing but your salbutamol. Salmeterol is your longest acting one. And what is bambuterol, guys? What is bambuterol? Yeah. What is bambuterol? Bambuterol is nothing but your terbutaline. Which beta blocker has antioxidant property? Celiprolol, carvedilol, pitaxolol, propanolol. That's your carvedilol. Which beta blocker has membrane stabilizing property? Membrane stabilizing property. Atenolol, metoprolol, propanolol, or esmolol. Membrane stabilizing property means the lidocaine property. Lidocaine like property. Lidocaine like property. Hmm? Which one is it? Metoprolol, atenolol, propanolol और esmolol? ऐसा लग रहा है मैं सब्जी बेच रहा हूँ तुम्हारे लिए, है ना? ऐसा लग रहा है कि आई एम सेलिंग द veggies around your colonies. So propanolol. Beta blocker having both alpha and beta blocking property, carvedilol, sotalol, nandrolol or pindolol. That's obviously your carvedilol. Okay, that's it for this session. We'll be right back at 3 p.m. in which we'll be doing the autocoids, starting the autocoids, and do join in that session also. I hope this session is very much helpful for you, and these classes are very much helpful for you in order to revise the things as much as you can. Thank you so much for joining, guys, and all the very best.